MRI or CAT scan. So if somebody develops memory problem a year, 2 years ago, and they are, say, 75, 80 years of age, and they want to make sure that there is nothing else going on, then they can get an MRI or a CAT scan. CAT scan would be easier, simpler. MRI is for people who have either some risk of strokes, or we are suspecting some kind of infection or multiple sclerosis or something like that. Then MRI helps more. But CAT scan is a fairly good deal, and you get a quick assessment, simpler test. So there are differences in MRI, and that helps us to diagnose Alzheimer's disease. Like I said, there are some of this is all research quality. There's another test you may have heard about. It's called PET, positron emission tomography. It is something that is used in cancer diagnosis. And what it does is the MRI shows how the brain is built. You saw that the cells were shrunk and the gaps and all that. That's what MRI shows. MRI doesn't show if these cells are functioning or not functioning, if they are able to transport materials or not. PET scan can show it. So this is, this is just a explanation of how the PET scan works. When we have certain functions, the part of the brain that is functioning for that particular activity lights up. Lights up means that it would show up on a computer. So when we hear words, this part of the brain lights up. When we speak words, this part. So this helps us to determine what part of the brain are not functioning as they should work. So it's a technology that is moving forward. It is again not available for in clinical practice. It is available for cancer diagnosis, but not available for Alzheimer's disease diagnosis at this point in clinical practice. Although in research it is becoming more and more available. It is used in cancer, it's used in brain malignancy, the PET scan, but it is not available for clinical use here. There are some of the differences. It can help us. So if you put those, this is one piece that will help us solve the puzzle. So if we have memory problems, we have MRI, we have neuropsych testing, we have spinal fluid analysis, and then we have PET scan, we can complete the puzzle. The other reason that we look at some of these things is that we have known over time that people who have a certain number of chemical changes, they are at a higher risk of Alzheimer's disease than others are. So one of the things is a gene called ApoE type gene. It increases the risk with age, and people who have that have a higher risk of Alzheimer's disease than people who do not. But the problem is that it is, again, there are some people who may not have that gene, yet they can get Alzheimer's. It's a small number, but there is. We're trying to refine science at this point so that in future we can use it. This is just a graph showing that, people, like I said, people who have this ApoE gene have a higher risk. They get they get Alzheimer's disease more likely than those who do not. Another thing in research is that we can look at the volume or the size of the hippocampus, and those who have lower size have a higher risk. That's why some of the studies that you may have heard about look at the MRIs on multiple occasions to check on the volumes. Another thing is in the spinal fluid there is a protein, beta amyloid. We look at the number of that protein, and depending on what the number is, that can also help us. Some of you may have heard about ADNI study, Alzheimer's Neuroimaging Initiative. It's a very important milestone. It's sort of a major study in Alzheimer's area that is going on. It has pretty much all major pharmaceutical companies involved, as well as National Institute of Aging. It is becoming an international effort. There is so much information coming out of this that it's impressive. And what it is that it is trying to learn how the disease progresses from normal to Alzheimer's disease. And it uses cognitive testing, MRIs, PET scans, and cerebrospinal fluid. And then it can put all these pieces and look at how people change from normal to go through mild cognitive impairment and go through Alzheimer's disease. So the point is that if we know how they go, we can detect what exactly is happening, what kind of treatments could be needed. In addition, it will also reduce the cost of doing such studies. So instead of having 500 people and all just doing memory testing, we can combine certain tests and do the same study in, say, 100 people. That would save the cost. And it has done this. And some of the information that I shared has come out of that study. It is using for the first time these chemicals. The concept of prodromal Alzheimer's disease is coming out of that study. It's showing that people who have memory problem and also have their changes in their spinal fluid are at higher risk. There are several other initiatives going on through National Institute of Aging using MRI and PET scans. There are genetic studies looking at genes, certain genes that are more likely implicated in Alzheimer's disease. All are targeted towards, an earlier stages, so we can diagnose Alzheimer's disease as early as possible. The other advantage would be with these techniques, we will be able to tell what medications are working and what medications are not working. So we can track by looking at the MRI and spinal fluid and their memory testing and say these drugs are actually stopping the problem or these are slowing down and how much slow down. So they can help us. They will reduce the number of people required, they will reduce the cost, they will help us determine if the medications are actually working or not, and what's the degree of their help. Another thing this study is doing is, I pointed out that we were talking about mild cognitive impairment. This study is taking it another step backwards. So it's moving close to normal. So what you see here, it used to be closer to Alzheimer's disease when we would diagnose it. Now we are trying to diagnose it at one step before that. This is moving closer to normal and using the same technology, same techniques, MRI, certain types of PET scans, spinal fluid, and diagnose it early. These would be the people who you could often say they're just normal. They're almost normal. But we are trying to find ways that we can detect it right there and then and stop it and bring some treatments.
So, sir, is it your imagination that someday you'll be able to test everybody to find out whether they have a mild case of dementia so that you can treat it properly in the very beginning? Because what baffles me is how do you determine who gets these treatments?
Yes. That's an important question that will remain. We won't be able to diagnose or detect in everybody, which would be impossible to do. So, for example, think about the colon cancer. Not everybody gets screened. Colon cancer at a certain age, if you are, say, I think it's 50 or 55, you go and you get a colonoscopy. Prostate cancer, you get about 50, 55. Breast cancer is about 40, 45 years of age where you get mammography. It's not for everybody. It's the same way. We know Alzheimer's disease rarely happens in people who are, say, 40 years of age. Okay? So, yes, we won't be able to have every 40-year-old and go through a lot of testing. That would not be practical to do. But we know that people who are at higher risk, for example, we will do, say somebody is 65. That person down the road will have an evaluation possible, and they may have one step, so there may be memory testing, and if their memory testing is fine, they would wait another, we'll come up with those guidelines, maybe 1 year or 2 years. But if they have a finding, a very strong history, or there is a blood test that can help us, or a spinal tap, and that can show, maybe in those cases we will do more. So we will categorize based upon their risk. There will be family history, So I think those things are coming. It will depend on how inexpensive these tests become. These are right now very expensive tests. I mean, a PET scan could cost about $8,000 to $10,000. As a community, as a society, we can't afford it, $8,000 test for everybody. But down the road, these may become much easier to do. Mammography is much cheaper than probably it was 20 years ago. So same thing will happen with Alzheimer's disease. All right, so there are other aspects of the disease treatment that are going on. One is the cardiovascular, cerebrovascular disease. I said that, vascular dementia is a common cause. It sometimes coexists with Alzheimer's disease. So there are treatments going on looking at the combination of Alzheimer's disease and vascular dementia or cerebrovascular disease. There are ways such as controlling diabetes or helping with blood pressure medications to minimize the impact of that. Now, a question was raised about what happens, the progression. So the ways to treat Alzheimer's disease right now is, if you don't treat the Alzheimer's disease, this is how it goes. The medications that we have right now are doing this. What they are doing is that they're lifting this line upwards. So the quality of life for those people who are affected is better. They can have some of the little more independence over a period of time. But these treatments are not cure. If we have treatments that will stop, that we are working on right now, this is what would happen. We'll arrest the disease where we detected it and where we treated it. So we'll stop. The person will stay where they were at the start of treatment. That's our hope. And my hope will be that we even don't get to this point, we stop it here or somewhere. Yes.
A couple slides back, there was some information on anti-cholinergic.
Oh, yes. I just didn't.
Explain that a little bit?
Okay. That's another part of assessment and evaluation. Like I said earlier, that some of the memory problems could be due to depression or anxiety, or especially when they're very mild and it's hard to tell if they have dementia or not. In those cases, you have to make sure that there is no medication that is making memory worse. There's no medical problem. Anticholinergics are certain drugs. These are drugs such as Benadryl, Tylenol PM, Imodium. Certain medications have this effect. Now, I'm not saying that people don't need those medications. So if somebody is on those medications, they should talk to their doctor. And doctors know about it. If they're on a high dose, then it means there is a higher chance. These drugs can affect memory and they can cause confusion. But a lot of times these drugs are used for pain and sleep, or for control of bladder symptoms, or control of diarrhea. So those type of medications are used. It's just part of evaluation to make sure that we do everything possible that we can do. So it's a good question. Thank you. Okay. So currently I said that beta amyloid medications that work on amyloid are going on. And their goal is to remove or clean amyloid from brain. And there are some which are given by IV infusion. Some are given by subcutaneous injections. The theory is that these are proteins, and these proteins can attack the Alzheimer's protein. So some of them do cause certain side effects too, because when the brain, when you manipulate the brain or manipulate any part of the body, there are certain side effects. That's what you get when you try medications. But it's a novel strategy that is being looked at this point. There are also medications called gamma secretase and beta secretase. These are another kind of chemical that are also targeting amyloid from forming. And they are also being tested. They are being tested in people who already have Alzheimer's disease, or people who are in very early stages of mild cognitive impairment and close to normal. They are also being tested. There are several other agents. Some of them are symptomatic. Some of them are working on certain brain cells. They're also being looked at. There are certain